الصورة كلير معانا يا دكتور محمد كده؟
كويس.
Our talk tonight will be about minimally invasive fixation in big joint fractures or major articular fractures. The main concept that must be always kept in mind and stressed on during any surgical procedures is that the soft tissue envelope and the biological environment of the fracture must be always respected. That is why to decrease the early and late post-operative complications. To do this and to avoid these complications, we have general rules to follow. First, the timing of the operation. Early intervention, as much as possible, must be always aimed to avoid surgery in the presence of massive soft tissue edema, because operation that is performed in the presence of severe intradermal edema or fracture blisters may increase the risk of wound tension, leading to sloughing of skin, tissue necrosis with subsequent infection and procedure failure. You must also decrease further soft tissue trauma and manipulations via, number one, limited surgical approaches, which we call mini incisions, minimal dissection and soft tissue stripping, minimal implants used, implants just enough to give stable internal fixation. The third point is early mobilization. Fourth is early weight bearing. Techniques to do this: for non-articular fractures, the percutaneous plate fixation or MIPO technique, biological plating, is well known. Close nailing, like interlocking end-rush pins, key wires, is also well known. External fixation in some open fractures is well known. But in articular fractures, we have several techniques and several areas of controversy, like arthroscopic fixation of small fragments, like avulsed tibial tuberosity, osteochondritis dissecans, when large enough. External fixation using ligamento-taxis plus or minus percutaneous pinning, and also have minimally invasive spinal surgery. Back to our topic, for large joint fractures, minimally invasive fixation with minimal incisions and minimal implants, with showing clinical examples. As a start, you should know that we have a management controversy. In this X-ray, this is Thompson-Epstein 5 with Pipkin 4 fracture dislocation hip. There is a little controversy here. This is a usual technique which could be placed with small plate for the stapler screws. And according to the best of my knowledge, this is the only available two techniques to use. And this is a follow-up for the patient, which is looking good. A little controversy exists in such a case. However, other comminuted interarticular fractures of the tibial plafond, tibial plateau, distal femur, distal end radius, distal end of humerus are considered among the most challenging orthopedic problems with controversial optimum treatment. That is because of the lot of complications we face. Most commonly is osteoarthritis. Rode and Alguer, in their huge series of about 4,000 plafond fractures, reported that osteoarthritis usually developed within 1 to 2 years after injury. Brad et al. Reported about 94% of fracture osteoarthritis, or nearly all of his cases of tibial plateau fractures, were complicated with early osteoarthritis. This post-traumatic osteoarthritis may occur as a result of damage to articular cartilage at the time of injury, and also the dissection and the periosteal stripping needed for reduction, fixation of articular fragments, or even that needed when small plates are used, as in the technique of indirect reduction external fixation. This can jeopardize more the vascularity of these fragments and increase the delayed union and the non-union rates, and also can explain the early development and the high arthritis rates, and subsequently the high reoperation rate in many articular fractures. So several investigators returned back to an old principle that was described first in 1965 by Czech, who advocated reconstruction of the joint surface with limited open reduction. And he said that little soft tissue stripping is needed for this technique. Tips for this technique is the most notable evolution in the management of articular fractures is the increasing emphasis on early motion, provided that the damaged structures are reasonably stabilized, not essentially rigid, just reasonable stabilization, or stable fixation, not essentially rigid. This when protected during motion and active motion is permitted as much as pain as swelling allows. This one of the very good tips for good results. Similarly, when we have stable, again, not essentially rigid internal fixation, early weight bearing has not resulted in either late displacement of the fracture or a delay in healing as advocated by many authors in many reports. University hospitals and faculty of medicine, our place of work. So again, we have basic rules. Early intervention, limited surgical approaches or mini incisions, minimal dissection and soft tissue stripping, minimal implants enough to give stable internal fixation, early mobilization, and the early weight bearing. This is a summary of the last slides. A clinical examples for this. In the lower limb, the tibial pilon fracture. This biological minimal fixation. As a rapid review, the name pilon comes from the French word pistil or rame. A pilon fracture involves the distal tibial articular surface. Interarticular extension into the tibial plafond makes it the pilon fracture. They are considered among the most challenging orthopedic problems. More than 20% of them are open fractures, and the optimum treatment of these fractures is very controversial. The famous classification of Rede and Alguer, type 1, 2, 3, is well known, and the Ovadia Beals added two types, 4 and 5, for metaphyseal and diaphyseal extension is a very conclusive classification. To revise the management of this plafond fracture, in the late 60s and 70s, the traditional treatment of these fractures was non-operative, but the results were non-satisfactory, especially loss of motion and non-union. This opinion was replaced later by the principle of open reduction and rigid internal fixation, but early post-operative problems were marked and have included skin necrosis, superficial and deep infection, loss of fixation, and even amputation in some cases. Complications with fracture healing or leg complication included delayed union, non-union of metaphyseal and diaphyseal fracture, varus or valgus malalignment of the distal part of the tibia, and non-anatomical reduction or post-operative loss of reduction of the articular surface. External fixation with limited internal fixation has gained some popularity since late 80s to abolish the high rates of complication demonstrated by the open reduction internal fixation. However, recorded complication rates were variable. The operation rates also were still high, especially those for delayed or non-union. And the optimum treatment of this type of fracture remains still controversial. We have our Banha experience in this minimal internal fixation by doing limited open reduction, minimal internal fixation of the tibia via multiple small separate incisions directly positioned over the displaced main fragments. Sometimes fixation was achieved through an open wound, which occurs usually in more than 20% of cases. Only intrafragmental screws, plus or minus transfixing wires were used. These wires were used to hold the reduction provisionally. Sometimes were left holding the reduction till union. For the fibula, small leg screws, K-wires, or rush pin were always the choice. When the fibular fracture was not comminuted, it was reduced and fixed first. Otherwise, fibular fracture was managed after tibial fixation. Intraoperatively, a femoral distractor may be used to assess achieving proper length and reduction in cases showing marked comminution. Endogenous cancellous bone grafting to fill substantial grafts is a must and is applied via small separate incision. The general rules we said before, like physical therapy, usually was used 2 to 3 weeks post-operatively, and weight bearing was allowed 3 to 5 weeks post-operative according to the progress of callus formation and disappearance of local tenderness and pain on weight bearing. Started with 2 touch and increasing weight bearing gradually with continued physiotherapy. The average follow-up showed that sound consolidation can occur in average of about 10 weeks. By that time, full weight bearing was allowed. Evaluation criteria, the usual criteria for fracture healing and soft tissue healing, according to the famous classifications known, using famous known radiologic and clinical scoring or classifications. And we have encountered bone healing in nearly all of cases in about 10 weeks in average with delayed union in 16% of fractures. The final clinical results with the limited fixation was excellent and good in about 75% of cases and fair in 1% and poor in 16% of cases. The most common complications were delayed union and superficial wound infection. As an example, this is Ovidia Peels type 5 fracture. This is a preoperative X-ray. This is a CT showing the proximity and extent of the fracture and the degree of articular comminution. This is the limited internal fixation using screw to fix the medial malleolus, screws for different major fragments like leg screws. This is 6 weeks post-operative, and this is 16 weeks post-operative with the patient doing push off and heel, walking nicely, and as you see, very limited minimal scars here on the patient's leg. Another case, Ovidia type 5 also, is also 14 weeks post-operative. Very good sound union. Here, 2 screws for the fibular fracture and different leg screws in different directions according to the direction of the fracture fragments. Moving to another point, percutaneous screw fixation of unicondylar tibial plateau fractures. Fractures of tibial plateau are common injuries having treated by a variety of operative and non-operative methods. Most clinical studies described open reduction and depleting of displaced injuries. Precise reduction of the articular surface with stable fixation restores the mechanical axis, allowing early mobilization. Ligamentous stability and preservation of the menisci are important for a long-lasting result. But open reduction and internal fixation of these fractures has a significant complication rate, and the numerous recent reports have a tendency to avoid open plating in favor of a variety of limited surgical approaches and percutaneous techniques, usually in association with external fixation. This is the famous Schweitzer et al. Classification. The preferred technique is closed manipulation, indirect reduction, and percutaneous screw fixation for Schweitzer types 1, 2, 3, or 4. The reduction technique by closed manipulations with the joystick technique, the fractures are fixed temporarily with percutaneous K-wires. These K-wires were used to hold the reduction provisionally till confirmed of the accuracy of reduction by different X-ray views in 2 planes at least. Then cannulated screws are added or solid screws beside the K-wires. Like this type of fracture. This is depression, split fracture. We have a big depressed fragment here. This is a triangular big depression. This is the split. By the joystick, this is the heavy K wire used as a joystick to elevate the fragment. This is the reference wire for the joint line. This is temporary transfixing K wires. This is the anti-glide wire. This is transfixing K wire. And this is the fixation of the patient 3 months later. Very nice sound bone union with very well congruent articular surface and incorporation of the bone graft, cancellous bone graft. Post-operative above knee cast for 3 weeks is usually used, with another 2 weeks for more comminuted fractures. Early physical therapy and partial weight bearing, usually 4 to 6 weeks, was used. Full weight bearing usually allowed after sound union with an average of 9 weeks. Is little delayed than the plateau fracture, the plafond fractures. This is a radiological evaluation of bone healing and complication rates, articular probability, and the clinical scoring of HSS and Iowa knee score, which was very nice results compared with the arthroscopically assisted or combined external and internal fixation union rate, articular congruity rate with less complications. This is a total complication rate. Most common is delayed union and loosening of implants. Although early motion has been shown to be beneficial after treatment of articular injuries, the knee may be immobilized for up to 6 to 8 weeks without causing obvious errors or bad drawbacks to the joint on long-term problems. No significant difference in the final end results were found between cases with perfect or anatomical reduction and those with articular incongruity of grade 1 or 2. Many authors also reported the same, that good results can occur with non-anatomic reduction with a depression or a gap 3 to 10 millimeters. However, we don't allow this big gap or this depression or displacement. Malalignment of the proximal part of the tibia with the shaft is known to contribute to a poor outcome following tibial plateau fractures. So varus angulation should be always prevented because it is poorly tolerated. These results were found to be comparable with those using ligamentotaxis and limited internal fixation or ligamentotaxis and arthroscopically assisted osteosynthesis. Another example, this is the lateral plateau depression split fracture. This is CT on the right. How much defect we have here? Big depression. And this is the follow-up of the patient after incorporation of the graft with sound articular congruity. Another point is the distal femoral articular fracture. This example of grade 3B open distal femoral fracture with severe comminution, limited internal fixation with only screws fixing a lot of fragments, lateral condyle fragments, intercondylar fragments, posterior condyle fragment. This is jamming of the articular component and binding the articular to the metaphyseal part with 2 K wires and 1 screw. And this is a follow-up of the patient after several months. This could be augmented with casting or with bridging external fixation. This is another example of limited internal fixation or minimal internal fixation of distal femoral fractures with very nice joint surface and bone union, 3 months post-operative. Up to the upper limb, the intercondylar humeral fractures. This is the famous Risbro and Radin classification, type 1, 2, 3, 4. In the literature, the most notable evolution in the management of elbow injuries is increasing emphasis on early motion, provided that the damaged structures are reasonably stabilized stable, not essentially rigid. Protected the early motion, and active motion is permitted as much as pain and swelling allows, even from the first week post-surgery. Open reduction and internal fixation by multiple key wires and cancellous screws only via limited posterior approach of the elbow is our preferred technique. By a small straight 8 centimeters posterior incision, triceps splitting incision, like in this case, type 4 fracture with severe comminution and displacement. This is nearly a fracture dislocation. This is screw fixation, fixing the two condyles, transfixing K wires, and major fragment fixation with separate screws. This is 3 weeks post-operative and several months post-operative on the right. Another case, also type 4, another limited internal fixation, 3 months post-operative. Another case, this is 4 months post-operative. We have good callus formation here with accepted alignment. Another case, also type 4, this is 6 months post-operative. All these are recent cases. Also, we have some old or mal-managed or neglected cases like this case. This is 6 months post-operative done elsewhere. This is a big coronoid fragment, radial head fragment, lateral condylar fragment, splitting and comminution of the olecranon. This is complete reconstruction with limited internal fixation. This is screw fixing the lateral condyle fragment. This is for olecranon fragment. This is also for olecranon fragments. This is for olecranon from posterior. This is late follow-up X-ray with good joint space, clear joint space. And this is a patient function about 7 months post-operative. Good elbow range, supination, pronation, flexion, extension. Again, in the upper limb, example of minimal fixation of unstable distal end radial fractures. As you know, the impact of Colles teaching led many surgeons to refer loosely to any distal radial fracture as a Colles fracture. And because of its frequency and the impact of the old teaching, it is usually managed by inexperienced junior staffs with unfortunate results with significant functional defects. It is important to have 3 important measures on the frontal radiograph: radial angle, or what is called ulnar inclination. This is the radial angle or ulnar inclination, radial height or shortening, and radial shift or lateral displacement. On the lateral radiograph, you have the dorsal angle or volar inclination and the dorsal shift or dorsal displacement. This is a reversal of the volar shift. To have one or more of these criteria, your radial fracture is considered as unstable fracture and it should be managed non-conservative. Whatever, plating, external fixation, percutaneous spinning, but is liable to redisplacement even after perfect reduction. These criteria of instability are dorsal angulation more than 10 degrees, radial shortening more than 5 millimeters as compared to the other side, significant volar or dorsal comminution, fracture gap or depression more than 2 millimeters, fracture extension with the radiocarpal and or radioulnar joint, and an accompanied ulnar fracture, whatever styloid neck or distal shaft ulnar fracture. This is a Frickman classification of fractures. As example of this limited internal fixation, there are several techniques for percutaneous spinning, like this Frickman type 8 fracture. This is radiocarpal, radioulnar fracture, radial ulnar styloid fracture. This is type 8 Frickman. This is ulnoradial pinning and radial styloid pinning, and this is the final results. Very nice restoration of all parameters in the AP and lateral X-ray. Another case with radio-ulnar pinning, radial styloid pinning, and Kaplan-G, dorsal or dorsomedial corner support. This is for the dorsomedial corner fragment, and this is the radio-ulnar pin from the lateral view, and this is the final end result of the patient. Another type is Frickman type 7. This is a modification of the ray hack technique. This is the internal construct, which is a modified ray hack, ulno radial fixation in this manner, restoring the height and all parameters, and this is the final end results of the patient. Another Frickman type 6, and this is radial styloid pin, this is dorsomedial pin, this is dorsal radial pin, and this is ulnar fixation of the ulnar fracture. This is the final end result of the patient after 3 months. Sometimes we have more fracture comminution and displacement, which is not amenable for fixation with K-wires. So we should resort to external fixation or ligamento-taxis. Like this Frickman type 7 fracture with this big dorsomedial corner fracture and radio-ulnar incongruity, reversed volar tilt, radial height loss. This is after distraction. This is the conversion pin technique. This is a distractor. And this is also converging pin technique. This is the good reduction. And this is the final end result of the patient. This case is also Frickman type 8, but with a real bag of bone. There is many fragments here which is not amenable of any type of internal fixation or K-wire reconstruction. However, with distraction in this way, as you know, we put the proximal pin here in the basis of the second, third, and fourth, and the distal pin in the base of the second metacarpal only. This is a distractor to change length and adjust the joint clear space. And this is the lateral view. This is the bag of bone after filling with a cancellous graft here through a dorsal small incision. And this is a patient finally after 3 months with some residual radio-ulnar incongruity. Don't forget that we have also the osteotaxis for extra-articular fractures. To summarize, for distal radial fractures, do not do simple manipulation and casting for an unstable distal radial fracture. You can delay operation up to 18 days with no harm. Simple pinning or ligamento-taxis are very successful. You should mobilize early. Hinged arthrodiastasis is better in the rest. Sodic atrophy is the most common complication with distal radial fractures. For elbow fractures, you should operate early. Anatomical reduction is a must. Stable, not essential rigid fixation, plus early protected mobilization can achieve good result. It is better to avoid ligamento-taxis because of bad tolerability of the elbow to distraction, even with the hinged arthrodiastasis, and the highest complication rate is myositis ossificans for the elbow. For the plateau fractures, you should operate early, also stable, not essential rigid fixation, plus early protected mobilization can achieve good result. Anatomical articular congruity is not a must for the plateau fractures. A step or gap of 2 up to 10 millimeters by some authors could give final good results, but poor tolerability to varus malalignment that should be always prevented. For plateau fractures, you should delay weight bearing. Plateau poorly resists strains of early weight bearing, so you should delay it. It has fair tolerability for ligamento-taxis as compared to elbow and wrist. For plafond fractures, also you should operate early, but anatomical reduction here is a must. Stable, not essentially rigid fixation plus early protected mobilization can give you good result. Early protected weight bearing is allowed in plafond fractures because plafond can withstand early weight bearing. The most common complication is pseudic atrophy. Plafond fracture have better tolerability for ligamentotaxis more than the knee or plateau fractures. To conclude, limited open reduction and minimal stable, not essentially rigid internal fixation with early protected mobilization is a satisfactory method for treating most displaced articular fractures and is associated with reduction of bone healing time, complications, and reoperation rates. You can do a lot with a screw. You can do more by key wires. We can do most of articular fixations with both. Thank you for attention.
Thank you so much, Professor Ahmad Allam, for this very interesting talk. And now we are ready to receive questions from our dear attendees. We have a question to Professor Ala Zuhairi. Is submuscular technique plate should be small through small incision?
Yes, this is what's called this invasive technique. We make a small incision and we go in the plane between the extraperiosteal but submuscular. By your finger, you can give way to your plate in this plane, but not use incisions. By your finger, just the plate will go inside this plane, extraperiosteal but submuscular.
Yes. Another question to you, sir. Strain peri theory for healing. He wants an explanation of strain peri theory for healing.
Strain, yes. If we put some stress on the fracture, what's called is bit of movement. It's allowed 0.2 millimeter in all directions will stimulate callus formation. But if more than this, will change into non-union and pseudoarthrosis.
Yeah. Another question for you, sir. In case of distal tibial fracture, do you apply cast with screw fixation?
Not full cast, but just the posterior slab.
Yeah.
And the elevation of the limb to decrease the possibility for edema and apply for good circulation. And we don't apply full weight bearing, but partial weight bearing by some crutches or something like that.
Yes, sir. We have
otherwise we get the stiffness of joints. Our aim is equalization.
Yeah. We have a question to Professor Allam. Where is the exact site of tibial plateau rafting screws?
Exact site for tibial plateau, what, please?
Rafting screws.
Grafting?
Rafting.
Drafting screws. You should position the screws according to the position of the fragment. Sometimes you have the fragment more anterior, more posterior. You should centralize it as much as possible, being at least 1 centimeter subcondylar, and you can add another screw which is called the anti-glide one. But you should be in the center or the body of the major fragment. You should always have at least 2 screws.
Yes. Another question to Professor Ala. How easy getting fractures in good reposition?
After reduction?
Yeah, how easy getting fractures in good reposition?
Yes,
after
we try as possible for the articular fracture is anatomical reduction. Either it must be by open reduction.
Yeah.
All articular fractures must be reduced by open direct visualization to all the fragments to return the anatomical position of all the fragments, what's called anatomical reduction. But in diaphyseal fractures, we just need an indirect reduction.
Yes.
And for preservation of the lens alignment, and as I told them, no exception for rotation. Lens and alignment, but no rotation.
Of course. Thank you, sir. Another question to Professor Allam. Would you mention, please, the principles and rule of Kappanji in distal radius fixation?
In fact, Kappanji percutaneous pinning is an excellent technique for reduction of distal radial fractures. You usually have to put 3 K wires if you make a pure Kappanji. In the examples I showed to you, you have a mixed Kappanji with other techniques. It is not a problem. But if you want to make a pure Kappanji, you should start with a radial pin. You enter your K wire with your hand directly from the lateral side, direct perpendicular to the fracture side. Just to enter the distal radius, move nearly to the middle of the radius and redirect it, the wire, proximally toward the elbow, about 70 degrees. By this maneuver, you elevate the distal fragment or the styloid up and restore the radial height, and push it with your hand to feel the medial radial cortex, then complete with the power to penetrate the medial radial cortex. This is the first wire from the radial side. Then you should have at least 2 dorsal wires, one opposite the scaphoid, one opposite the leonate, because you usually have a dorsomedial cornal fracture. Even with ligamento-taxis, this dorsomedial fracture doesn't restore because it is devoid of ligamentous attachment. So you put a dorsal wire in the plane of the scaphoid to elevate the main radial fragment, and another one in the plane of the leonate to elevate the dorsomedial corner or the die punch fracture. You do it with the same technique, perpendicular to the fracture side till the middle of the lumen or the cavity of the radius, redirect it proximally, more or less vertical, about 70 degrees, push it till you engage the radial cortex, and then penetrate it with the power reed, the power source.
Yes, we have. Yes, sir. Thank you. We have a comment from our dear Professor Muhammad Abdelal. To operate early in distal, in tibial plateau, is a term to be revised, as most of these injuries are accompanied by soft tissue injuries, whether evident or hidden. So the very famous statement, span, scan, and plan. What's your comment, Professor Allam?
Yes. Alan Muhammad.
تفضل دكتور علاء بيه. تفضل استاذ.
Yes, you know the new theory from Muhammad about the classification of upper tibial plateau fracture, what's called the 3-column classification of the tibial plateau fracture. Now we don't depend on Scheisker classification. Scheisker now finished his classification, and now the new classification is the 3-column theory. That is the lateral column, or what's called the valgus column, medial column, which is called the varus column, and the posterior column. All columns must be treated, each one by one plate alone. The medial by a plate, the lateral by a plate, and the posterior by a plate. There may be a combination between 2 columns, or 1 column, or 3 columns, but you put the idea that each column must be by its incision or combined incision, but must be fixed. Before fixation is the reduction. How to reach the reduction? You must span by traction and anatomical reduction, because this is a joint. So you must put this in mind, that you must do anatomical reduction, then fix each column alone with preservation of the soft tissue because this area is very vulnerable for compartmental syndrome. You know that the vessels, popliteal vessels, after division into anterior and posterior branches, will pass from the back of the knee to the front of the leg in the upper tibia through an opening in the periosteal opening. The vessel will go through this opening to the anterior compartment. If in this area some collection of blood or hematoma or pressure by a tourniquet or something like that, this will lead to ischemia of all the lower limb. So we must scan, and good reduction, rigid internal fixation, but the reduction must be anatomical reduction.
Yes, sir. Thank you, sir. We have, sorry, we have lots of questions. Another question from Dr. Muhammad Ali to Dr. Professor Allam. In articular fracture, do you use screws only? Do you think that using screws only can withstand fractures or withstand loads, I think he mean?
Yeah. When you use enough screws supporting all major fragments and you protect these screws for reasonable time, whatever by avoiding weight bearing, supporting slab, bridging external fixator, yes, it is enough because the healing rate is better than or faster than open reduction. So if you have screws in the proper position, and as Professor Ala said, with anatomical reduction of the joint surface, it is a cancellous area. It heals rapidly. When you protect it well, yes, it can withstand stresses.
Yeah, we have another very nice question. In tibial plateau fracture, if it is depressed, how to reduce it in a closed manner?
At the X-ray I showed to you, you make a very small incision, just a half centimeter, and introduce a heavy key wire, or you can introduce a little broad instrument like an periosteal elevator, small one, or a blunt dissector below the depressed fragment under C-arm control, and you push it up. This is an old technique, and all of us do it. It is not a difficult one, but the most important is after you elevate this, if you don't fix it, it will fall down again. You push it up. When you are sure it is in the joint line level, you transfix it with a K-wire and either do the mode of fixation you want to do or put the graft in it and fix the graft also with another screw or K-wire.
Yeah, I'm sorry, Professor Ahmad, I have a very nice technique. I did it with the depressed type tibial plateau fracture. I put a K-wire in an oblique manner and making it like a joystick and elevate the depressed fragment, and they put another K-wire and cannulated screws is put in it. It's very easy and very simple technique by manipulating the depressed fragment by the joystick technique, and it gives excellent results.
Very good.
What do you think about it?
Yes, as Dr. Ala said, everyone do the thing that he thinks that he can do it well.
Yeah.
This is not firm rules. The tools you can do it, you master well, you should do it. You are better in this area. Dr. Ala is better in this area. I am better in this area. The technique you are mastering well, giving you good result, is the best technique you should do.
Yeah. You mean that in a very simple fracture or even complicated fracture, there is nothing called the unique solution of this fracture. We have many solutions of just one kind of fracture.
Yeah, there is no one solution for everything.
Yeah, yeah, of course.
Every fracture, I always say that every fracture has its own personality, and you should deal with its own personality.
Yeah.
How many times you face a fracture that is not classified?
Yeah.
Not fitting to any classification you see.
Yeah.
What about this, Dr. Ala?
Yes, I agree.
Many fractures not classified.
Yes, yes, many fractures. Yes.
Yeah. Professor Ala.
And multi-trauma patients or polytrauma patients, usually many fractures, many types of fractures, and in the same patient you can use different techniques.
Yes, of course. That's absolutely right.
Open fracture, closed reduction. See, every patient by his or any part of the patient will, in this case, will take one of the techniques.
Yes.
Professor Allam, in case of distal femoral fracture treated by screws, what type of stability when bear weight?
As Dr. Ahmad Allam said, it is not only screws.
Yeah.
Not only screws, because the shearing forces after operation will break and destroy the screws. Yes. After either you put a neutralization plate by less invasive technique, or as Dr. Ahmad Allam said, you can put external fixation or plaster. But I think external fixation or a plate is better than plaster, because we need early mobilization of the joint.
Yeah, you're right, sir. Of course, that's what Dr. Muhammad Al-Mahdi said in his comment. Absolute stability for joints not done by key wires, so need neutral plates with intrafragmentary screws. What do you think, Professor Allam?
Absolute stability for joints for cancellous bone, in my opinion, from my own experience and a lot of other person's experience, is not a must. Again, it is a stable fixation which is protected enough till union is enough. It is not a must to have rigid fixation in articular fractures. Just stable with enough protection.
And another question about the how long do you keep your patient non-weight bearing after percutaneous fixation of distal tibial fracture?
For distal tibial fractures, usually 5 to 6 weeks. But for plafond fractures, usually 3 to 4 weeks, you can start tip to touch. And it is also a matter of a change according to the personality of fracture and the progressive union you notice in X-ray.
Yeah, thank you so much. We come now to the end of the questions. At the end, I would like to express my deep thanks from the bottom of my heart to our great professor, Professor Allam Zuhairi, one of the cornerstones of AO in Egypt and Switzerland. Thank you so much, sir, for being with us tonight. شكرا جزيلا أستاذنا الفاضل.
Wishes to all of you and all our colleagues in Banha University, and usually we hope more and more for scientific events from Banha.
والشكر الجزيل موصول لحضرتك يا أستاذنا, to my dear brother and my dear friend Professor Ahmad Allam for his very interesting talk about the mini invasive fixation of big joints fracture. Thank you so much, Professor Ahmad. وده ختام المسك بالنسبة لكورس الجنرال تروما. احنا هنبدأ إن شاء الله next Wednesday يوم الأربعاء إن شاء الله مع upper limb trauma course. It's a very scientific course, very condensed course, about 3 weeks. معانا في الكورس الupper limb معانا speakers من كل الجامعات المصرية, معانا speakers من USA, معانا speakers من UK, معانا speakers من ألمانيا, من إيطاليا, من البرازيل, من أيرلندا. فإن شاء الله هيكون very fruitful and very scientific course. الله يبارك في سيادتك يا أستاذنا, بوجود حضرتك يا دكتور علاء بيه.
عاوزت أي حاجة أنا في أي وقت معاك.
ربنا يخلي حضرتك يا فندم, متشكرين تواجد حضرتك معانا, شرف كبير لنا يا فندم. فإن شاء الله نشوف حضراتكم يوم الأربعاء في بداية كورس الأبر ليم. Thank you so much, Professor Allam. Thank you so much, Professor Ahmad, and have a very good night. Thank you so much.
شكرا
تصبح على خير. شكرا دكتور علاء بيه. تصبح على ألف خير. شكرا دكتور أحمد.
مع السلامة.
تصبح على خير يا فندم.
انت مع السلامة.